I was asked to present on technical pearls for occluder therapy. I'll be focusing the conversation mostly on FDA-approved devices such as Watchman. To review, steps involved in left atrial appendage occlusion procedure involve a transseptal puncture, multimodality imaging, implantation of a device, and release of a device. Anatomic variability can greatly influence the success of your procedure as well as the length of the procedure time. The things you need to do ahead of time are define the osteal plane, measure your dimensions so you can appropriately size your device, and then figure out a way to deliver the device in a coaxial manner. The top 3 factors that are going to affect your procedural success involve the difficulty of the transseptal puncture, whether or not you can get enough depth in your left atrial appendage, and then whether you can get your sheath coaxial or not. This diagram depicts the anatomy of the fossa, and it also shows typical crossing points for various left atrial procedures. The red star indicates a typical crossing location for a left atrial appendage occlusion procedure and is in the inferior and posterior segment of the fossa. There are several anatomic features which can greatly complicate your transseptal crossing. Having a small fossa or one that has a lot of lipomatous hypertrophy will greatly reduce your ability to select your perfect transseptal crossing location and may dictate the crossing segment for you. If you have a thicker fibrous septum, it may be difficult to get across. And then finally, having a tortuous IVC can certainly restrict your ability to torque the catheter. We typically use the Brockenbra needle for transseptal crossing in our lab, but it's important to always have a backup option. Some labs use the back end of a wire to get across when it's difficult to puncture. We typically use radiofrequency ablation with the Baylis transseptal crossing system. I find that to be particularly helpful in 2 types of anatomies. The first would be the middle pane here, the fibrotic septum, where no matter how hard you lean on the septum, you just can't get across. So I find the Baylis to be useful in getting across in those instances. And then second is the aneurysmal or the stretchy septum, where you find that when you're leaning on it, you can't get across, but you end up in the middle of the atrium. The radiofrequency needle will get right across in those types of anatomies. Tortuous anatomy can greatly impact your ability to perform a transseptal. This is an extreme case, but you can imagine this would really impact your ability to torque your guide. Whenever I encounter tortuous venous anatomy, I always use a long sheath with a telescoping guide technique. Typically, I'll use a 14 by 45 centimeter or longer sheath, and then I'll put my transseptal guide within the inside of that sheath. That does 2 things. It'll straighten out the IVC for me, and then it also reduces friction points in an area of bend. If that doesn't work, you can put a buddy wire up with a Lunderquist wire, which will help to straighten things out. This particular example on the right screen shows you that when we're about to do our transseptal puncture, as the needle is going across, you can see how far leftward we are on the screen. That really exemplifies the fact that this is a very tortuous anatomy. In this particular case, after we crossed with the needle, we were unable to deliver the sheath and the dilator through the septum. So we ended up having to put a stiff wire into the left atrium and then using a 10 millimeter balloon. And you can see here that there's still a waist, but ultimately we were able to get the waist to give and then the sheath would go across. Switching gears a little bit, let's talk about when there isn't enough depth to deliver your device. This is an example of a short but wide appendage. Here's an example of an appendage with very prominent pectinate, which will prevent your feet from expanding properly. And then here's an example of multiple small lobes. These anatomies can pose a challenge and certainly make your procedure more difficult, but it is possible to perform appendage occlusion in these anatomies. When I first learned how to do left atrial appendage occlusion, the typical teaching was that you needed as much depth as you needed width for your ostium of your appendage. However, that's not exactly true anymore. We were also told that you could never advance your delivery system and that everything had to be advanced over a pigtail. While that's a very important principle and is a safe practice, we have learned that once the feet start to open on the Watchman device, the tip is not quite as traumatic as it was when it was closed. And so if you give it a little time and let it expand, you can sometimes safely advance your device on the delivery cable to gain a couple of extra millimeters to be able to implant your device. The Watchman Flex device is going to offer some major advantages in this regard. It's a shorter device, and so you don't have to have as much depth to implant. The other thing is that the leading edges are round, and so the whole IFU is going to be different, and they're going to actually encourage you to push the device in. So the whole procedure will change once this becomes commercially available either later this year or in 2021. Finally, there are a few things that can affect your ability to get coaxial. The most important, I would say, is the septal crossing location. The delivery cable can sometimes cause some wire bias, and then if you have a prominent Coumadin ridge or complex left atrial anatomy, that will affect your ability to get coaxial as well. The Watchman delivery sheath comes in 3 preformed curves. The double curve is the one that I use probably 80 or 90% of the time. The single curve I don't find to be as useful, but it can help for either a posterior chicken wing or a posterior windsock. And then the anterior curve I find can be very helpful as well in anatomies where I just, no matter how much counterclockwise torque I put on the system, it just doesn't get me coaxial. This is an example of where changing a guide sheath actually helps you a lot. When you do the initial angiogram here, you see that there's an anterior chicken wing, and it's going to be difficult to get coaxial. You'll see here in the middle pane that when we use the double curve sheath, we're very horizontal, and despite my attempts to counterclock the guide and get it to point up, really we were without much success. So we took the time and swapped out the guide. This is an anterior guide in the third pane on the right, and you can see that we're a lot more coaxial with the plane that we want to be delivering the device. By no means are we perfect. We could do a lot better, but it's a big improvement from the double curve sheath. There are other things you can do too besides swapping out your sheath. So if you find that's not enough, you can go ahead and repeat your transseptal crossing location. You probably go 1 centimeter or so inferior and perhaps anterior, and then recross. And then you'll find that you've basically taken an entirely different trajectory. And in this particular case, that's what we've done. So the middle pane basically demonstrates the coaxiality of the sheath through the initial transseptal crossing location. And then the third pane shows you that we are much more coaxial when we take a slightly different transseptal location or course. In summary, anatomic variability is a limiting factor for left atrial appendage occluder therapy. A stepwise approach to anatomic limitations results in an improved success, and ongoing device improvements will simplify the procedure greatly. Thank you very much.